Let's talk about Friedrich's ataxia. So Friedrich's ataxia is the most common form of inherited ataxias. It comprises of almost 50% of all the hereditary ataxia. Occurs in a classic form or in association with a genetically determined vitamin E deficiency syndrome. So there are two forms. One is a classic form and one is genetically determined vitamin E deficiency syndrome. And both the two forms are clinically indistinguishable. So the age of presentation is usually before 25 years of age. There is staggering gait, frequent falling and titubation. The lower extremities are more severely involved than the upper ones. Dysarthria occasionally is the presenting symptom. Rarely, progressive scoliosis, foot deformity, nystagmus or cardiopathy or cardiomyopathy is the initial sign. So coming to the neurological examination, nystagmus, loss of past saccadic eye movements. So saccades is the fast movement. Now what are basically saccades? Imagine you're sitting in a room, okay, and suddenly one beautiful girl enters. So suddenly your eyes move towards that girl. So that fast movement is known as saccade. So there is loss of that fast movement. Truncal titubation, dysarthria, dysmetria, and ataxia of trunk and limb movements. Extensor plantar response with normal tone in trunk and extremities. So the extensor plantar is extensor with normal tone in the trunk muscles as well as the extremity muscles. There is absence of deep tendon reflexes, very important. So what are the differential diagnosis of absent DTR is a very important MCQ. If you think very commonly or if you have been working in your internship in the wards or especially in the ICU, if you have ICU postings, you will see that first differential diagnosis will be Guillain-Barré syndrome or GBS. The second differential will be what is hypokalemic periodic paralysis. In periodic paralysis, there is areflexia and there is ascending type of paralysis. Then if the lesion is a UMN lesion, but in case of spinal shock, like the initial stage, the DTRs are absent, right? And fourth differential diagnosis might be neuroparalytic snake bite. So there is absence of deep tendon reflexes and weakness greater distally than the proximally. Distal muscle weakness is more than the proximal muscles. So what are the differential diagnosis of proximal muscle weakness? One is GBS, again hypokalemic periodic paralysis, and all kind of myopathies. So myopathies will usually involve the proximal muscles. Then what will cause predominantly distal muscle weakness, which we see in a common scenario, is the UMN or the UMN lesions, stroke, any kind of bleed, any kind of tumor, all these can will cause more distal muscle weakness than the proximal. Loss of vibratory and proprioceptive sensation occurs. Usually, loss of vibratory and proprioceptive sensation is the function of which column? It is a function of the posterior column. The median age of death in case of Friedrich's ataxia is 35 years. Women have a significantly better prognosis than the male gender. So, if you study, one thing I want to tell you guys is that once you study this topic, study all the differential diagnoses are related to the same topic. Now, nystagmus. So, what are the duties of nystagmus? What are the types of nystagmus? Horizontal gaze nystagmus, vertical gaze nystagmus, torsional gaze nystagmus. So, in what all conditions they are present, the mechanism of action you should know. Saccadic movements I told you, right? Truncal titubation is most commonly seen in cerebellar lesions. Dysarthria, dysmetria, again cerebellar lesions. So all these, each and every line, if you understand the differential diagnosis and pathophysiology of the symptoms, you will be at a better position than your counterparts or the people who are giving the exam. You will be better among the rat race. So cardiac involvement occurs in 90% of the patients. Cardiomegaly, symmetric hypertrophy, murmurs, and conduction defects are reported. Moderate mental retardations or psychiatric syndromes are present in a small percentage of patients. A high incidence of diabetes mellitus is found and is associated with insulin resistance and pancreatic beta cell dysfunction. Musculoskeletal deformities are common and include PS cavis, that is flat foot, PS equinovarus, and scoliosis. MRI of spinal cord shows atrophy, very important point. Now coming to the pathogenesis, the primary sites of pathology are the spinal cord, dorsal root ganglion, and the peripheral nerves. Slight atrophy of the cerebellum and cerebral gyri can occur. Sclerosis and degeneration occur predominantly in the spinocerebellar tracts, lateral corticospinal tract, and posterior cortex. So if you see the symptoms and if you correlate with the pathology, the cerebellar system symptoms like nystagmus, titubation, dysarthria, dysmetria are present. The dorsal root ganglion and peripheral nerves, posterior column for loss of position and vibration sense is present. Lateral corticospinal tract symptoms are present, right? So if you correlate, you will be able to understand better. Degenerate of the glossopharyngeal, vagus, hypoglossal, and deep cerebellar nuclei is described. The cerebral cortex is histologically normal except for loss of Bett cell in the precentral gyri, very important MCQ. The peripheral nerves are extensively involved and loss of large myelinated fibers. Cardiac pathology consists of myocytic hypertrophy and fibrosis, focal vascular fibromuscular dysplasia with subintimal or medial deposition of myocytopathy with usual pleomorphic nuclei and focal degeneration of nerves and cardiac ganglia. The classical form of Friedrich's ataxia have been mapped to 9q13q21.1 and the mutant gene frataxin, again important MCQ, contains expanded GAA triplet repeats in the first intron. The two forms of hereditary ataxia associated with abnormalities in the interaction of vitamin E alpha tocopherol with very low density lipoproteins have been delineated. A-beta lipoproteinemia, that is Basin-Konsvik syndrome, and ataxia with vitamin E deficiency. So these two names you are supposed to remember. You are supposed to remember that both the forms are clinically indistinguishable.